Support.
If not, all in favor, say yes.
Yeah.
Opposed, same. Second, we have a motion to, if I can have a motion to approve the minutes of March 27, 2022.
So moved.
Second.
Comments, questions on the minutes of March 27. Not all in favor, say yes. Opposed, same. This is our first opportunity for public comment. Any folks?
I would like to make
Really
public
good
comment.
person, City of Grand Haven and the Momentum Center. Last month, I had the opportunity to present to the board, and a number of our members were here. Today, they'd like to make public comment to share their good experiences with the Momentum. If you can, sir.
Sure.
I think a member volunteer, the woman for 6 years, 7 years, maybe. I can say is when I was there, started out on a government grant for senior citizens to be employed. And that ran out, I had to go to another job. So, but still, I stayed as a member. And I say one thing, all the members down there, they all be along. They help each other, care about each other, they do things for each other. The rest of the world, we have no wars. Everything we do. They do, they care about each other, and they work together, one each other, one final place is safe haven for them. One place for them to go, and then enjoy it. Richard Watson, Dave, been here since just about when they opened, and won't hear any. There was a question at the end of it about whether or not the different people get along. And they get along just fine. Everybody, I mean, we have arguments and things like that, but nobody asks anybody what their illness is, or what their their choice is. So they just meet them and they try to read everybody their ones. And I see why. Doesn't matter. Whether they're broken or something. Probably a lot. He says.
Yeah, I volunteer there and we get along with people there. And everybody that comes there to the door there, we try to get along with people there.
I'm Judy and I'm a volunteer and a member, and like Richard said, we welcome everybody, no matter what our race is or our handicap is, and we like to help each other, and in this time of need of moving, it's going to be hard to cope and not being at the center for this end of this week and just trying to find other things to do. Well, it's going to be Coast Guard, weekend. And hopefully that a lot of us can get to, doing different things by, we're not gonna be able to go to the center. And hopefully that we can do a lot for our new place that we're gonna move into. Thank you.
Thank you.
Things with medicine, but it's the thing. But this is for the person that has. They have a fun so that I can still on it, I mean, that room is still in it. So, hopefully we can keep it open.
That's all the members that wanted to speak. And they mentioned this is a big week for us, when we move in the new, old rendezvous or new location. We're doing that through a land contract that we organized with the owner. None of the millage money is going toward that. We'll be doing a capital campaign so that we can pay it off, because the land contract with the balloon is not long-term sustainable. But it's allowing us to get into a place that's much more visible and accessible, and that gives us many more opportunities and possibilities for providing members service. And I think it's important to know we had over 500 member check-ins in June. We had over 200 touch points with members. We have 30 members who are there at one of the locations, Holland or Grand Haven, almost every day. It really is their community. And in the past 2 weeks, we literally referred 2 people to the hospital who were actively suicidal. So the work we're doing is incredibly important, and I want to applaud the members and their bravery for speaking today. Thank you.
Thank you, Barbara. Any other comments?
We have one person online.
I want to talk about what's been in the news paper about Pearson's County walked away from an adult foster home, not only once but twice. And hopefully hoping the issues are addressed with his home. It's unacceptable. That's tragedy waiting to happen. And if we have a microphone for people that speak, so people on Zoom can hear what's being said in the audience.
Thank you, Liz. Any other comments?
Yeah, we have Michelle Barnes from online.
Hi, thank you for letting
Hold
me
on one
come
second, Michelle,
in.
you're muted. If you could unmute, please.
Can you
Thank
hear me now? You can hear me?
Oh, our speaker's not working. One moment, please. Try now.
Hi, can you hear me now?
Thank you.
Yes, go ahead.
Thank you. Thank you for having me here today. My name is Michelle Massey Barnes. I wanted to let your board members know that I was scrolling through my Facebook feed the way that a lot of people do when they need to take a break at the end of the evening. And I was pretty horrified to come across an article by MLive that described some pretty offensive and derogatory language that one of your board members used in relationship to a Rolling Stones editor. That is a pretty high profile email to use such offensive language about individuals with developmental disabilities. I don't know if I can put my disgust into words. I get it that people say things that they don't mean sometimes. I have as well, but I would really like to see an apology on behalf of the entire community of individuals with developmental disabilities and their family members and the people who love them. I can tell you that as a parent group, we have over 650 parents in our group. We span every single political background you can imagine. And over a year and a half, we have successfully avoided making mental health and behavioral health a political issue. And in one email that got publicized across MLive, a board member offended an entire community and turned this into a political issue about whether or not a Rolling Stones editor was woke or exhibited a developmental disability himself. It's really offensive, and I hope that a formal apology is issued on behalf of Ottawa County Community Mental Health and on behalf of the LRE. Thank you.
Thank you. Someone else is. Go ahead.
I'm Denise Newhouse. I have some show and tell. This is what happened to my daughter, her group home. The first week of the month. This is her roommate who did this to her. She has to sleep next to this girl. And it's like this, I saw her yesterday again, my daughter, and they're starting to heal. But she goes, is this gonna leave a scar like this one over here that was done to me in Flint Township? And it's like, I told my daughter just has to live with it. And that family sleeping. Then Kayla got up. She was excited. Our friends and sunshine was out for lunch. And the roommate woke up and did this to her. And this isn't the first time this roommate has done this. It's many times. And how do we get a safe place? My daughter is loud. She gets aggressive, but I don't think she's ever done damage like this. I mean, my mama's heart hurts so bad. And that's what I just want to figure out how we help her. I mean, she's 26 years old now. Her brain was soaked in alcohol while she was growing. And she lives in this house with other aggressive individuals, which but she's been doing much better. But I would have tons of anxiety and depression. That's what I would. Thank you.
Any other comments?
Hello, my hand is up. This is Jewel Wickman.
All right, go
May
ahead.
Thank you. My topic is asking the board to evaluate all the benefit plans, enrollment, and eligibility criteria that CMH of Ottawa County is responsible for providing to their Medicaid recipients based on their contractual obligations with the state and CMH and their prepaid health plan, which is Lakeshore Regional Entity, and the CMH contracts. So looking at the fiscal year 2024 proposed budget that is going to be discussed today, and the past board minutes for years under the current leadership, these CMH OC board meetings sound more like a mental health millage meeting supporting the CCBHC initiative. There is absolutely no oversight of the managed care Medicaid programs and general funds. The board of directors give authorization to Lynn Doyle to sign contracts between the state and CMHOC and Lakeshore Regional Entity as a prepaid inpatient health plan and CMH for delivery of contracts for delivery of services within those contracts for the $40 million that is entrusted to CMH to provide to the most vulnerable people to keep them out of crisis. A good portion of these funds are protected under the home and community-based final rule that allows the most severely disabled and elderly to choose meaningful services that are individualized to meet their needs and desires to live meaningful lives fully integrated in their community. Integration is not what Momentum is doing. The millage is paying for Momentum's model to intentionally integrate IDD, SMI, and SUD in one facility, which most resembles a psychiatric hospital that takes us back about 60 years. The home and community-based services mandate integration of IDD with the greater community, with people who aren't Medicaid recipients. So I feel like the millage is actually being weaponized against people who want freedom. And I urge the board to please look into this. The home and community-based waiver programs mandate full inclusion within the community for people not receiving Medicaid services. That's why conflict-free access and planning is in place by the home and community-based final rule, which CMH never discusses, to prevent entities who receive the funding from referring internally and benefiting financially. The home and community-based final rule is meant to prevent exploitation of the elderly and disabled. Unfortunately, the most vulnerable, disabled, and elderly are being denied their freedom of choice and not even being told their options for all the money that CMH receives for their care. That is why CMH recipients are called consumers, because CMH must agree to purchase the supports and services for them using the prepaid Medicaid funds. Underutilization of Medicaid services intended to prevent crisis are
Thank you,
resulting in overutilization of the
Thank you, Ms.
Medicaid system.
Wickman. Your time is up. Are there any other comments?
Yes, my name is Rachel Murray, and I'm calling in because I read about the article from your board member who used the derogatory term to refer to his the clients of your Ottawa CMH. And I would like to call for that person's resignation. They have no business overseeing the services that are provided to that community when he obviously does not respect the community. I don't know what his experience is with that community, but he is not aware of some of the most basic principles that of respect that need to lead the work that he does. So I would like to call for his resignation.
Okay, thank you for your comment. Ma'am, you may go now.
Hi, my name is Kara Boston. I'm from. Crisis doesn't happen everybody. We moved here about 7 years ago from Oakland County. And out there, we have a lot of support. Within his school, we have a lot of inclusion. There's friendship circle. My son has school martial arts. There were just all kinds of things going on. My son has severe food animal allergies, and it seemed really because everything is focused on food. And when they came over here, it was very isolating for us. We didn't know people and autism classroom. And then his senior year, we had COVID shut down, where he didn't have a chance to say goodbye to his classmates. And then it started off with the doing the over the computer classes where he just couldn't integrate with that. It just, things were building up. My husband was in the hospital for 5 weeks. I ended up getting diagnosed with cancer. So we had isolated and COVID. And then my cancer diagnosis was really devastating, not knowing how long I was going to live and what to do with my child. It's a long story, more than 3 minutes, but nothing without crisis. When you're in crisis, they tell you to go to ER. ER doesn't want you, but they say go home, you'll be more comfortable. And we went home, and he was put on some meds he couldn't really manage. He was put on a plane for 6 weeks, and then he ended up in ER again. He ended up with the state and placed into a group home, where it's really hard for our population of IDP that don't have a lot of language how to explain this to him. And he's in a group home out of county where it's hard for me to visit him. He likes to be physically active. And we're welcome to go and take him for bikes. But with recovering from my cancer, and it's an aggressive cancer that comes back, that it's hard to go and give him the supports he needs. The group home, they're lovely people, but it's hard for 2 workers to get them out anything physically where he's used to going to around 5 nights. So it would be nice if there were like more support, more physical support for our individuals where they could get out into the community. Autism rates started increasing the year my son was born and climbing. And the school ends at 26, and it's funny that these people out to the community, getting more physical activity, but that really helps with the kids and their needs. So right now, he really does need more one-on-one CLS, and I'm trying to do that with alongside.
Rockman on line.
David? Is he muted or?
I'm checking one right here. Let's see. He's not muted. Stephen, are you there? His hand is raised. Okay, Karen Simon.
Hello, thank you for having me. I appreciate your time today. I am the parent of a 19-year-old developmentally disabled young lady. And I am very disgusted and appalled at the comments made by Jason Monroe regarding the developmental disability population. The fact that he is employed by the agency that is providing services or supposed to be providing services to my daughter is just ridiculous. I'm sorry, but I don't see how he is qualified to be working in this agency when he has no compassion and empathy for this population. I second Rachel's request for his resignation. This is totally unacceptable. I thank you for your time.
Thank you. Any other comments?
Yes, my name is Natalie Anwar. I'm also a part of the organization on Facebook for which Michelle Massey and Rachel Murray are part of. I have 3 children with autism who have would be qualified as level 3 autism, severely autistic, nonverbal. And the term that he used, Mr. Monroe used, is extremely derogatory. I understand that you guys have a policy that you talk are to treat everyone with dignity and respect. That is a severe breach of your own mission or your own standards and practices. That is not treating anyone with dignity and respect, and it does further just make it difficult for those in the mental health community who have struggled with developmental disabilities to get the support and understanding that they deserve. And I also agree that he needs to resign, or there needs to be some type of disciplinary action that happens with this individual. Thank you.
Thank you. Do we have any more comments? If not, we will move on with our agenda to new business. Brianna?
Excuse me. The first order of business is the quarterly report that I usually provide everybody. This month encapsulates March, April, May, and June complaints. You can see the opened and closed, open 2 complaints, closed 2 in March, open 4, closed 5 complaints in April, open 5, closed 5 complaints in May, and then opened 3 complaints and closed 2 complaints in June. All of the reports, length of days, status reports that were sent out. You'll see that, we have 90 days to complete a report. So you want to see a number lower than 90 days in that last column. And then the outcome is dependent upon what the Michigan Mental Health Code requires. So any abuse, neglect, retaliation, and harassment substantiation would require disciplinary action. That's what the Michigan Mental Health Code requires. Any other code protected rights, such as like a dignity and respect that you'll see on here, sanitary treatment environment, disclosure of confidential information, mental health services suited to condition, those categories would require remedial action minimally. And so the difference between the 2 of them is remedial action could include a verbal coaching, where disciplinary action starts at least a written reprimand. And so when I ask for remedial or disciplinary action from either internally, it's one of a community mental health staff, or
externally to one of our contractual providers, I simply just quote what the Michigan Mental Health Code states, and then we make sure that they've actually taken the minimum at least required. And so we don't be prescriptive in that, because you might have someone who's had, 2 no call, no shows. And if I say, oh, I want a verbal warning or something, and they're thinking, no, I want to fire this person, they can go above and beyond the minimum requirements. So all of the outcomes meet the Michigan Mental Health Code standards, and that is what we need to assure. You'll see in March through June a summary of the incident reports. That's different than the complaints. So incident reports are noticeable things that happen. If any physical management was necessary, behaviors such as harm to self, harm to others, peer-to-peer interactions. Maybe someone left the property and followed by staff, that kind of thing, emergency medical treatment. And so you'll see a summary of those. We average in the 180s per month. Sometimes there's more, sometimes there's a little less. There's no rhyme or reason to that, but we have paper copies coming in and we have electronic copies coming in. So that's been really nice for our home to submit an electronic incident report. They type it out, it comes immediately to me, and then I can send them a copy back if they would like a copy. So, and then you'll see a summary of the outing or the committees that I participate in, and then site reviews. That's a new one. The Lakeshore Regional Entity ceased doing recipient rights portion of the site reviews, I think beginning in January. And so the rights offices within the region here have worked really hard to try to come up with a system to do site reviews more efficiently, because we've noticed many of us contract with the same providers within our region and then also out of our catchment area. And so we have designed a site review tool that has all of our names on there, all of our logos. We have common memos that we send out after we do site reviews. And so in May and June, I've started site reviews. July, I've done a number more. So it'll continue. I have an assigned list as well as every other rights officer within the region. And we've, the state, the Michigan Department of Health and Human Services Office of Recipient Rights have reviewed our process, and they seem to be okay with it so far. So I just completed a tri-annual rights assessment last week, and they seem to, still be okay with the site review tool that we've been using. So I think this will be really, really a great process for all of us within the region, the rights offices, to have this. It's been working really well so far. And then on the last page, you'll see trainings virtually through the Network 180 training. So they are getting a ton of people through that training. Staff are required to have recipient rights training within the first 30 days of hire. That has improved dramatically since COVID, and having this virtual training available, and also the improving MI practices training is an online training that people can do at their own pace. And numbers have definitely gone up with compliance with training within 30 days. So that's a really good thing to see. And then the annual update is out there, the 2023 Recipient Rights Annual Update, and people are continue to go through that as their timeframes come up. So.
Brianna, a question.
Sure.
Under the complaints.
Yep.
In March, the last 2 complaints in there.
Yep. Those, yes, I did not complete those. Yep. So it was 3673 was done in April, and 3674.
Okay, I see that.
Yep. Okay.
Gretchen,
Or a statement from the public comments. So the gentleman who's been walking away from his adult foster care, have there been any steps taken to mitigate kind of elopement and then risk? for them?
That individual is a COFR, so he doesn't fall under my jurisdiction.
He's not in my jurisdiction. No.
Yes. I will say there probably has been some steps though, definitely. Mhm.
Plus, it seems to migrate to water, which is really.
Yes,
Yeah.
for sure, for sure.
but it's been an ongoing.
Would that be in the Sweden jurisdiction? Maybe I was just assuming since it's in Grand Haven.
We have a lot of people who live in Ottawa County that do not receive services from Ottawa County. They still, receive services, like for example, we have a big program in Ottawa County that Hope Network runs, and there's 30 people who live at this site. And I don't think we have one Ottawa County person who lives there. So there could be 30 counties represented, and they do their own rights investigations for them. Yeah.
Ottawa County, even though the adult foster care
Mhm.
in Ottawa
Mhm.
County by individual county that they come from, that an investigation.
Yep. Yep. And sometimes, if there's a rights office represented from the Upper Peninsula and they have a rights investigation, they could call me and say, would you do courtesy interviews for us or ask for assistance? But yes, they do their own rights protection.
So then just to follow that, I'm just still learning everything.
Yes.
So if they come from a different county to Ottawa County to live at that group home or wherever they're at, does the money follow them from their county, or does our county then pick up that person's expense?
In a COFR situation,
What's
COFR stands for County of Financial Responsibility.
Okay.
And the county where that person.
They would be
financially
responsible.
responsible.
Right. So then one more quick question, kind of like to piggyback Gretchen to Denise, who talked about her daughter. I couldn't, were those bite marks or what was that? I couldn't scratch. So is that in Ottawa County or where is that happening?
She's an Ottawa County recipient. She lives out of the county.
Okay.
So we have.
So do we follow up on that?
We follow up with that, yes.
Complaint been filed.
A complaint has not been filed yet.
Thank you.
Related question.
Yes.
So then it sounds like the different counties follow the residents or the consumers who live there. And then is there somebody who oversees the licensing of that entity? Is that separate?
Yes. So that's through Laura. And every licensed adult foster care home has a licensing consultant. Yes. So a lot of times with some of the complaints, you won't only have a recipient rights officer investigating. You'll have, a rights officer, you'll have an adult foster care licensing consultant, and sometimes an adult protective services worker.
Gretchen, sorry.
I think I asked the question before. Did you get back to me and I apologize.
You did.
Approximately. off the top.
I don't want to, I can tell you in 1 second while I find my email.
While Lynn is looking for that, is there anyone else that has a question? Or a comment? This is your chance to ask, especially for the board. Come back to Lynn when she has it. Is there any open? That's okay. Is there any old business?
We should have a report. We're not done yet.
You want me to keep going?
Oh, I'm sorry.
I got more.
Brianna's got lots. Just getting started.
I know, sorry, my apologies. Sorry, just.
We have moments.
So twice a year, I have to send a report to the Michigan Department of Health and Human Services. So at the end of June, the semi-annual report was due. And so you have that in your packet. And that is just kind of like a 6-month capture of where we're at before the annual report comes out. This is a really simple report to do. It's very much easier than the annual report. And so you'll see they ask for a number of consumers served, unduplicated count, and this is not inclusive of individuals receiving substance use disorder services. The total number of complaints from October to the end of March is 29, 25 allegations, 25 investigations, 14 of those 25 allegations were a substantiation was found. So corrective action, remedial, or disciplinary action was required. And then on the following pages, it just represents the category, kind of what I do on that quarterly report. It represents the category that the 25 allegations fall under. And then next is the policy review, and we just had the triannual assessment last week, and they reviewed all of the policies that we submit. This is the document that I send to them if anybody wants to look at it. It has page numbers and where to find the exact element that they require. And it was interesting because, you know, the state of Michigan's Office of Recipient Rights, they require a certain policies, like 23 policies. And so right away on the first day, we got a really big compliment about our policies, about how organized they are, how well, like it kind of follows almost exactly how these go in order, and how they really appreciated that. And so they asked if they could share our policies and our formats with other counties while they do assessments to help them and make it easier for them and have I guess, an example to go by, which of course I said, absolutely. But you will notice in the policies, I did make the change that you requested about the review and the revised dates. But no changes to the policies, and all of our policies were reviewed by the Michigan Department of Health and Human Services during this triannual assessment. Last time they only reviewed about 5 of them, but they did all of them this time, and we got a perfect score on that section. So no changes to any of the policies. And then, as promised, because we have so many new members here, I thought I would just pick a citation or two just to give you a quick overview about certain things that we look at when complaints come in. And dignity and respect is definitely one of the biggest or the most frequent complaints received. And so, you know, mental health services suited to condition, you go to the next slide when you're ready, is we want staff to be familiar with everybody's individual plan of service. They need to know the goals and objectives that someone is, you know, authorized to receive within the plan. When I get involved, it's when that is not being done. So, you know, somebody may have like occupational therapy, physical therapy, something like that in their plan. And I can think of one from a few years ago. We had a group home that just couldn't seem to get the person to their physical therapy appointments on time. And the physical therapist wrote a letter to us and said, man, they just can't get here on time, and they've missed this appointment, and this appointment. Well, that falls under services suited to condition. And so we, you know, looked at that. We substantiated services suited to condition against probably the home manager at the time. and made them put a plan of correction in place on how that person was going to get to their physical therapy appointments on time, how they were going to assure that that was done, and we monitored that. So from a rights perspective, I'm looking at what's the service that's authorized, is it being done? I do not overturn decisions about amount, scope, and duration. I do not overturn if a service is authorized or denied or terminated or suspended. It is pretty cut and dry, like what's the service in the IPOS? Was it done? Was it done to the frequency that is prescribed, etc.? So even on the next slide, it's just, you know, knowing that individual's plan. Years ago, I used to have staff come into training and they would say, what's an individual plan of service? And I would say, oh my goodness, what? That should be the first thing that you should look at. And they said, okay, when we go back, we're going to ask our manager, can we read it? And I was like, absolutely, because you need to know how many times you need to be out in the community doing community outings or whatever else. Is there a behavior plan? And knowing all of that information. So in a nutshell, that is services suited to condition. And then I also highlighted dignity and respect. So dignity is treating people with esteem, honor, and politeness, addressing individuals in a manner that's not patronizing or condescending, treating people as equals, and treating people how they would like to be treated. And then we have respect, which is similar, treating recipients with concern, consideration, appreciation, maintaining privacy, being mindful of differences, allowing recipients to make their own decisions. And so my favorite thing to always talk about in a class when I do training is my cousin who has cerebral palsy. And for years, she did not want to go out in public because people stared at her. And so I tried to talk to people because, you know, strangers would come up to her and they would talk to her like she was 2 and she was 17 and kind of slow down their cadence, their tone would change. And so instead of going, hi, how are you today? They would say, hi, how are you? And she would just look at them and be like, no, you know, and shake her head. And so, you know, yeah, she can't feed herself and she can't dress herself, but she gets all of that. And if she could talk, she'd talk faster than I talk. And so, you know, making sure people know about their tone, about their cadence, facial expressions. We have people who don't smile a lot. We have people who smile way too much. And I probably fall into that category where those things kind of get you in trouble too. And so for dignity and respect, like you might be having a bad day and you don't want me to smile at you. And I need to be aware of that. And so just some other training examples, just being kind. We have people, it sounds ridiculous, like, well, I didn't shut the bathroom door because of this. Well, why? You know, well, I just ran to go get a towel while the person sat in their bedroom, just got out of the shower with no clothes on. I left the door open and people will call and I did not like that. Fair enough. And then using appropriate language, age appropriate language, and just being courteous, that kind of thing. So I remember another example years ago where we had a staff working in one of our crisis homes, and she thought that she and this other person participating in the service had a really good relationship, and she nicknamed him Crab Apple. And he thought it was really funny on Monday, but then when she came to work on Wednesday and said, how you doing, Crab Apple? He filed a complaint against her. And so knowing, you know, we tell people don't call anybody by a nickname they don't prefer. I had another gentleman file a complaint against his community living support worker because she kept calling him honey and sweetie. And he was 52 and she was 19. And she should respect her elders. You know, so it was, let's have this conversation. He did not feel respected, that kind of thing. So that's it for that, for those two. I'll pick 2 different ones next quarter. If you have a preference, let me know. I'll talk about it.
What's that?
I am, yeah.
Just wanna make sure.
You're asking.
Thank you for that.
Yes, you're welcome.
Any old business? It's the second opportunity for public comment.
I think that Stephen Rothman is still trying to get on, so.
Stephen, can you hear us?
I'm not. I don't know, he's not showing as muted, but Stephen, are you able to?
Okay.
Hmm.
Well, we'll have two more changes.
Yeah. Oh, wait. No, and Jewel Wickman also has her hand up.
Go ahead.
Jewel?
Hello, yes. So I have a question about what Ms. Fowler was mentioning about a crisis home. So are the crisis homes the same as the specialized residential stabilization programs that are funded by the millage, that where the money is repeatedly given to the largest nonprofit corporations? So way back in the board notes in 2016, it said that the CCBHC initiative was about health homes. So I Googled what a health home was. Health homes are behavioral health homes or opioid homes. So I was wondering, is that what the specialized residential programs have been all along? Are these behavioral health homes and opioid homes? And then I looked at one of the specialized residential websites for Beacon Specialized Residential, and they listed behavioral health homes as moderate, as low, moderate, and high. So I really urge that the CMH board take a deep dive into the adult foster care system and to see which homes are millage homes and which homes are protected by the home and community-based waivers. Because if these specialized residential homes are under the millage, who's regulating these? Is Brianna regulating these homes as if they're under the Medicaid rule, or is this under the CMH board? The individuals in the crisis homes, are they given dignity and respect? So if they're autistic, are they being medicated with antipsychotics and sedatives as part of the medication assisted therapy? I think that should be something that the board really looks into, because there's been a lot of contracts for medication assisted treatments. There's been a lot of contracts for a lot of crisis interventions. And I wonder if the board even knew that the specialized residential millage programs were crisis homes. So again, this is an opportunity where autistic individuals could be exploited because their symptoms are very similar to, could be misinterpreted by someone who's not educated in autism. They could think schizophrenia, they could think OCD, bipolar, and the ramifications would be that an autistic individual would then be treated with an antipsychotic, which would then encourage an autistic individual to run away from home to get away from these medications, which is why there's a lot of elopement out there. So again, please, I urge the board, there are 100 AFC homes. There are 4 specialized residential homes that consistently have been getting the same money, and they all are nonprofits that fall within the CCBHC provider network. And their contracts actually have an attachment for a DCO provider network. Thank you.
Thank you. Any other comments? If not, I will take a motion to adjourn.
Moved.
Or.
Yeah.
All right. Thank you. On to, anybody need a break? Start the board meeting. All right, I will call our board of directors for. It's in our invitation.
When in prayer, Lord, we do pray that today that you give us wisdom and discernment, help us to assist all the folks within our county in the best way that we can. Again, give us wisdom and fairness, and we thank you for how you lead us. We pray in Jesus' name, amen.
vision statement. And this will be our first opportunity for public comment.
Hi, I might as well go again.
No,
I'm sorry, my name is Joe
Not
Smalley, and I'm.
go ahead.
I just wanted to say about the Rolling Stone Monroe incident, like, it's not a solvable problem in this room. At the point that send was clicked, it became a political problem. And the reason why we have this political problem actually is in this room, because Sylvia Rhodey was the person that nominated the guy. And it was anticipated, like, if there was any type of due diligence done, it should have been anticipated that this person that was going to go off and say something that he should not have said. And it was deeply damaging to a large amount of people in this community. Unfortunately, because it is a political problem, the solution has to be political. And we're starting with somebody who did vote to support to have Monroe on this board, and we are recalling this evil. We have over 1,000 signatures on the recall petition, and the interesting thing is over 1,000 people have stopped and asked to sign the recall petition for Gretchen Cosby as well. So, I mean, we can anticipate that recall going on in the near future, and it should be even more robust than the program that we're running to make sure that Lucy is no longer on the board of directors, or board of commissioners for the county. But this is a horrible thing that's happened, and it's going to take a lot of work to undo the damage that these people have done. That was.
Thank you. Any other comments from people in the boardroom? Go ahead, ma'am.
May I speak?
No? Go ahead, ma'am.
It is a political problem, and we've had one. And if it's, and you're a consumer and you said something, then they can accept your apology or don't do whatever you can to just stay in the seat. Because otherwise they'll continue.
Thank you. Anyone else in the boardroom that has a comment?
I wonder, is this the public
Can you
hearing
state your name
for
again,
the
please?
budget?
Can you state your name again, please?
Is this the public here? Do they have this here? We're doing it at the county level. Oh.
September 1st. Anyone else in the boardroom? Okay. Jewel, are you still on?
Yes, sir.
You may go.
Thank you very much. So I wanted to, my topic today would be about transparency of the fiscal budget. So according to the board notes in April 2018 or 2019, Lynn Doyle asked to, I believe, dissolve the committee that reviewed the programs. There was a planning program oversight committee, and that committee was then dissolved. And then in 2021, Lynn Doyle asked for Chairman Fensky to then dissolve the finance committee. The finance committee's role in prior years was to review the contracts, review all of the finances prior to any CMH board meeting. And then that committee would present the details after reviewing the contracts themselves to the CMH board. That no longer has taken place in the last couple of years because of current management's direction to the board to appear less transparent to the community. So as evidenced by all of the board meetings, there is no way for the CMH board probably to go over the contracts. In fact, I don't even think the contracts are being reviewed or even being put in front of the board because that never was their responsibility in the past. It was always a finance committee that would review the contracts. So my request is that we return back to the previous agenda where there was a planning committee that would review all of the plans and the people enrolled in those plans and the eligibility and the supports and services and present them to the board, and the finance committee who would then review all of the contracts and all of the amendments and the budgets in detail, line by line, and then present them to the board. That would offer more transparency and better financial oversight. Thank you.
Any other comments? If not, then we'll move to the consent items on the agenda and have a motion to approve his agenda and the minutes.
Move.
For support. Or any comments, corrections? If not, all in favor, say yes. Next, we have a presentation by Mary Marlotte Dumas and Stephanie Vanderkoy, Lakeshore Regional Entity. Welcome, ladies.
Good afternoon. I want to thank the Ottawa board for allowing us to come present to you and the opportunity today to tell you who we are and what we do. So with me is Stephanie Vanderkoy. She is my Chief Operating Officer, and I am Mary Marlette Dumas, the Chief Executive Officer at Lakeshore Regional Entity. So today the things we'd like to discuss, and we're so we're going to take our questions at the end. We would like to return to make sure we're keeping already on schedule. So first off, we want to talk about who we are, what the relationships we have with the CMHs as a prepaid inpatient health plan, and we'll talk about what that is. Also, we want to share with you what forms of funding that we receive and how it flows through the Lakeshore Regional Entity out into the CMH and out to the individuals that are served. And then we'd like to take your questions towards the end of that time period. So who we are, as I said, we're Lakeshore Regional Entity, and right here it's referred to as LRE. So we are the Public Behavioral Health Managed Care Organization. Many of you have heard of Medicaid health plans that take care of physical health care. We are the Medicaid health plan that manages the money for behavioral health and substance use disorder. Under behavioral health, we refer to things of intellectual and developmental disabilities, mental illness, as well as your substance use disorder. So the LRA manages the services provided under contract to the MDHHS to residents of a 7-county region. And in those counties, we have Allegan, Kent, Lake, Mason, Muskegon, Oceana, and Ottawa. So at the bottom of your presentation, you will see we have our website. If you want questions, I'm hoping that the new website is more user-friendly as well as more informative. The first time I looked at it, I was a little baffled myself. So it's one of the projects that Stephanie took on, and it took us almost a year till we got it to a point that I felt it was really user-friendly. You will see in the state of Michigan, we have 10 PIHPs. We are Region 3, way off in that beautiful west side of Michigan in the green. We are one of the, I would say, smaller PIHPs. However, with Kent County, we end up having quite a financial basis to our region. We are a multi-county, as I said, and there's only 3 standalones, which would be 7, 8, 9, which is Oakland, Detroit, Wayne, and Macomb. The rest are multi-county PIHPs. So you will see who we are as far as our mission and vision. It took us the past 9 months till we finally came up to what are we looking for our mission and vision. And you can see local solutions. We really want to value the local differences because Ottawa County looks substantially different than Oceana County. And what goes on in Ottawa County will be much different than what goes on in Oceana County. We also want to be fiscally responsible. That has been a challenge in Region 3 for a number of years. So we want to have accountability and be responsible for the funds. We want to have collaborative relationships. We want to foster effective partnerships with our CMHs, as well as we want to be innovative. We want to be we want to boldly pursue excellence. And one of those examples is the CCBHC. We have 2 current demonstration CCBHCs being West Michigan and then Health West. And then we are moving into, by October 1, we hope that all 5 of the CMHs within Region 3 will be in the demonstration. So you will see on the next slide who we are. And I will tell you that's a lot of work right there. When I started, we had 7 employees. We had a company out of the state that we paid approximately $10 million a year to manage our managed care functions. And so when I took over in March of 2021, I started to bring staff back that were valued employees, as well as new individuals to get us off the ground. You will see that it's broke up into essentially 5 areas. We have a finance department on the left, moving on over into the operations, which is the left middle, which is Stephanie's department, you'll see, and that's probably our largest department. We have IT, we have quality on our far right, and then we also have compliance, which is a one-man show. So under our relationships, as I mentioned, we have On Point, who is Allegan County, Community Mental Health of Ottawa, all of you. Health West, which is Muskegon County, West Michigan CMH, which is a three-county CMH, and Network 180, which represents Kent County. I'm going to turn it over to Stephanie to begin to talk about some of the operations.
So on the next slide, one of the things that we have are what we call regional operation advisory teams, or ROTs. There are 10 of them under different subject areas, and some of those also have work groups as well. But that's really where we meet monthly to take a look at what's going on in the region and how we can work most efficiently. The next thing, what I started to do was try to break out for you, what are the managed care rules? What are the things we have to work on? So that's the list that's there for you. And I'm going to go through each one of those extremely quickly because I know you're on a time crunch. So the first one is general management. This just talks about, here we have to have financial solvency of our organization, making sure we're distributing the funds to our CMHs, and also ensuring our board members and contracted agencies and officers are free of conflict of interest, and that we also are not excluded from the Office of Inspector General list for sanctioned providers. So I'm going to go to the next slide, Patricia. Thank you. So financial management, there's a lot that goes on here. We have audits that we are responsible for financially. We also have a budget that we are responsible. We do revenue analysis. We look at expenses, monitoring, management. I feel like that department does so much, they need their own presentation. But for the spirit of going quicker, I'm going to say that's good. All right. So then we have information systems. Again, oodles of things that happen here, but this is where we really accept all of the authorizations come in, and we're making sure that folks are getting the correct care that they need. And we're having a whole department that really takes a look at all of that to ensure that the data is going from one CMH to a provider to another correctly. So it's basically a behavioral healthcare data and data system is basically what I'm trying to say here. And again, a lot goes on in that department. Provider network management. One of the biggest things that we do here is working on contracts, working with our local providers, policy development, credentialing, privileging, as well as we also create an annual network adequacy review and report. We do have to do that by the state, but we chose to do it annually, even though the state only requires it every year. We do it annually. So the next slide then goes into utilization management. This is a department that takes a look at access and eligibility determination, as well as we take a look too at utilization management protocols and tools to make sure they're as up to date as they can be and that we're matching state regulations and federal regulations. And then we also have an annual utilization management plan for fiscal year 24. That will be going to our board of directors this week, Wednesday, but it is on our website in the event you want to take a look at that. Then next we have customer services. We make sure that information and services that are compliant with the Code of Federal Regulations, we've listed that here for you. And we also have a customer services handbook and a guide to services. We have all that here linked in the event you want to take a peek at that. That's on our website. It's just recently published. Every year we do that, but it just got published recently. We also facilitate our consumer empowerment, and it's called the Community Advisory Panel. We have that as well. And then we also have them assist us with PIHP planning and development of our policies, procedures, and the work that we do. And then we also manage the complaints, grievances, and appeals of that department. And then the next slide should be quality management. This department does a lot. And the first thing that you see up there is called the Quality Assurance and Performance Improvement Program of QAPIP. This is what we're required to do annually. We also have to validate performance improvement plans, or sometimes you hear them called the PIP. We also in that department do auditing and monitoring of our providers, as well as offering education and oversight. And then I'm going to skip a couple things. And one of the last things that you see on there is this is an external audit by a group called Health Services Group, HSAG. That's a group that we work with annually that reviews us, and it's coming up soon. And you can see the excitement in my face. But no one, right? Anyway, it's a lot. It's a lot that we have to do with this. But anyway, that's one of the other things that this group does as well. And then compliance. This is making sure that we are managing everything within the region the way that it's supposed to be done. We also offer a lot of trainings in compliance for our board members, our staff. We do compliance reviews, investigations, and enforcement and discipline in this department. And then we work with the Office of Inspector General for reporting or suspecting fraud, waste, and abuse.
And then this is an area that I wanted to just touch on. We have funding coming in from different buckets. And so there's Medicaid, there's PA2 and block grant, and then we have specialty grants. And in the last few years, we've received several specialty grants. And so if you could just go to the next slide, please. Those focus more on substance use disorder, gambling prevention, and our veteran navigator program. And so these are some things that we do as well that I didn't already have a slide for. And so one of the things that I thought might be helpful for all of you to just recall, I know Joel Evers was here last month discussing what happens here for substance use disorder as far as treatment, but we manage prevention directly at the PIHP. And so here in Ottawa County, your prevention providers are Arbor Circle, right next door at the Department of Public Health, and then our friends right here at Ottawa CMH, Joel's team. So just wanted to mention that. And then we also have a veteran navigator who assists families as well as veterans, just making sure he's connecting individuals with resources that they may need across our 7-county catchment area. And then I think the next slide is, Mary already touched on it, CCDHC. The one thing I want to mention is we are the only region out of the 10 regions that have all of our CMHs participating in the CCDHC. I think you already covered that earlier. So I think we're good on that, unless you want to add to that.
No, I think for those of you who don't know, very complex, but it also, the really cool one with CCDHC is oftentimes in communities, because the public mental health system serves those that are considered persistently mentally ill. If you are a law enforcement officer out there responding to a complaint, you don't know what you're doing with an individual, if they're mild or moderate, or if they're severe, and if there's substance abuse involved in that. The CCBHC takes all of that away. It's one-stop shopping. We're able to serve the mild and moderate as well as the severe and persistent. So it actually is quite friendly. It should be alleviating the bottleneck of access. And for those of you who have followed Debbie Saldana, this is one of her programs that she is very passionate about. And it is sweeping the nation. And so it was a stressful year, this first year of the demonstration, because they were building the plane as we were flying. But we're starting to kind of smooth out a little bit. And it's a nice time for the other 3 CMHs to be joining the demonstration here too. And we are excited to see where that brings us.
Any questions or comments?
It's
No.
not.
Yeah,
So in our region, the certified behavioral health centers are stationed within our CMHs. And so it's like another funding bucket, and there's criteria for services that must be provided. But when people come in the door, they will be seen and it's running out through an assessment on what level of knowledge you might have. Should you be served by the MHP or should you be served by the CMH? You will be served by the CMH. So oftentimes when I hear people say behavioral health home, they actually think it's a building, and it's actually a model and a concept, same as the Opiate Health Home. It's not actually a home where you go live. It's where you go to get your services.
Just trying to understand how it improves access, just because we do know that.
Because we should,
by CMA.
because it doesn't matter if you're not, if you have an individual who maybe is in a crisis due to marital conflict. You could walk into a CCBHC and now you're struggling with depression. Typically, that's situational depression, and you probably, unless it is to a level that you are unable to maintain a job and those types of things, you wouldn't be served by CMH. That removes that barrier, and so you will be able to be seen by that population.
Regarding your team, are the team members, are many of them full-time with LRE, or are they like our Patricia, who are?
I believe Patricia is my one part-time LRE, part-time Ottawa County, and we leased her from Ottawa County. So I believe the way the benefit is set up, she's really not my employee, she's a leased individual.
That's gotta make it feel better, right?
Well, we are, it's just really don't. Oh, wait. Please don't tear me apart. When PIHPs came on board, I remember this board had a lot of discussion on what that was going to look like. Was there going to be a reduction in the number of people in the state who are handling, probably who previously handled some of the same things that you presented very well today. Has that been evaluated, like, how many fewer people do we need at the state level since we've switched up to this?
That's a really interesting question because I can tell you at the state, it's really skeletal. It truly is very skeletal to the point that, you know, we used to always talk about when I worked at another PHP about how lean we were, and being lean, that was always like a notch in your belt, but it comes at a cost. Your employees end up being overworked. You can't keep people because they turn over. And so having a lean PHP, there's that balance between wanting to be too lean, but lean. And I think honestly, the state, this is completely my opinion. I think the state is a little too lean. And so oftentimes more and more is being pushed down to the PHP, and more evaluation is happening and oversight at our level than what was initially pushed out almost 20 years ago. It was 2004, so 19 years ago. So more is coming to the PIHP than ever before. I think the other thing we are seeing at the state is they have a lot of really ambitious individuals there, but they don't have a lot of historical knowledge. And as you know, that every single year that you're in the system, you learn more. And so you know the history and you know the curve and the direction that it's went. So we have a lot of policymakers at the state. We don't have a lot of individuals that worked out in the system and in the field. And I think that creates this realistic challenge versus ideal. And what we think is ideal really always doesn't work out in the field realistically. And so those are some of the frustrations that as partners, as CMH PHPs together, continue to work on with the state, because it is a challenge. And sometimes when policy comes down, Steph and I met earlier today, that they pushed out a policy that I absolutely don't want to send out to any of my CMHs to follow. It's asking personal questions that I don't believe we should be asking. If somebody chooses to share that in therapy, it's their choice. But the first time they walk into a substance abuse session, that's not something as a past therapist that I want to ask them. So we're going to try to rally the troops. And how do we address this to let the state know? We turned down a tool that had these questions in it, but now you put it into a policy and brought it around the other way. So it's 6 to 1, half a dozen to another, but you have to pick your battles. Overall, I can tell you the PIHP runs across the state at about a 6% admin, and PIHPs stick within that. MHPs, 15% off the top. So at one time when 298 was pretty hot, and we were looking at an MHP stepping in, 15% of the funding would come off the top, and then the CMHs under that would get 9% less funding. And when you're talking about amount of services to individuals, that is millions of dollars. And so we will always continue to look really appetizing to the MHPs who have some pretty large lobbyists. They have a lot of money behind them. And so it is really important that we continue to support our association, Community Mental Health Association, and support Bob Sheehan's direction for us to keep us locally controlled and locally maintained.
One more question. It's about CCBHC. So I'm hearing you say that it will improve access. And to my understanding, it means because now you're going to be able to treat more mild and moderate units. What about services for the severe though? I mean, will those be diluted in any way, shape, or form, or should those?
They should still have the same services they always had, because it's based on medical necessity. And so if you qualify for the service today and you're reassessed in 6 months or a year, you should still qualify for the same services unless you've improved, but it's going to be based on the medical necessity.
Any other questions? Thank you, ladies. Thank you for the presentation. Opioid settlement proposal. Jessica and Joel.
So, I think most people are aware that, the state has received quite a bit of money related to the opiate settlement agreement. And we were asked as CMH, as one of the organizations, the primary organization that is dealing with substance use disorders, to come up with a plan for how to expend those funds that we're receiving here in Ottawa County. So
Joel and Jessica are here to let you know about our proposal.
Yeah, so I got to meet with you last month, and so thank you for having me back. I'm still on the program supervisor over at CDC. I have with me Jessica Irving on KWB Strategies. It's a consulting agency that we're contracted with to help us kind of gain some insight and some initial steps to use this opiate settlement funding. So she's going to give a little background on what these settlement funds are, where they're coming from, why we're getting them, and then their survey that they did, and then I'll follow up with kind of how we're going to, for our plans to take that and release that money through the RFP process.
Hi, everybody. I'm Jessica. So I want to start out by giving some background. I know Lynn said most of you are aware of the opiate settlement funds, but we're going to take a high level approach and just remind everybody a little bit about the background. So the opiate settlement funds is actually the result of a lawsuit. And so it was a national lawsuit because a lot of people died from opioid medication. When we look at the stats, 142.8 million prescriptions for opioids were filled in 2020 in Michigan, or that was nationally. 68,630 people died from overdose involving an opioid in 2020. And then 2,738 people died in Michigan from an overdose involving opioids in 2020. So when we look at this lawsuit, it's from pharmaceutical companies because of these deaths that happened across the country, astronomical amounts. Thank you. So my goal when we have these conversations, both here and then in municipalities, is to say, okay, how do we funnel all of this information? Because there's a lot of it. And the lawsuit broke out strategies for communities to fund into core strategy interventions and then approved strategy interventions. So the core strategy interventions is what they recommend, is what the lawsuit recommended. And so we're going to focus on those. What we did is we surveyed our providers and experts in the community, because we know that the people that are actually working in the community, individuals in recovery, that they're going to have the most expertise around how to use this funding. And then the goal is to present curated ideas to funders to be able to say, hey, this is what we should do in our community. So that was the approach we took. All right, again, just like what does this look like in a snapshot? It was a $26 billion settlement nationally. $800 million was allocated to Michigan, but that's over 18 years. So because this was such a big lawsuit and settlement, this is being distributed over 18 years. Half of that funding is being distributed to the state. Half of that funding was directly sent to local municipalities, and the amount was different. It was based on the number of overdoses that have overdose fatalities that happened in that area. And again, we're going to focus on because that's what was recommended by the lawsuit. So what did this survey look like? Again, we sent this out to professionals and experts in our own community, and we asked them to give feedback on two things. What strategies did they recommend overall? And we identified the top 3. And then we also asked them to look at categories. So looking at recovery services, treatment, and prevention, and say, hey, where do we need the most help or funding in our community? You can see here, we had a breakdown of survey recipients. So a lot of administration of nonprofits and treatment providers that work with individuals. We had substance use clinicians, prevention specialists, recovery coaches, and then as well as DHHS. And then locations of where their offices were. So again, across the county. So this is where what the survey said. So recovery services was number 1. This is where, everybody said, hey, that's good. That's where we want to put our funding. The second was the need for increased treatment, and the third was in prevention. So when we look at the power of partnership, I'm going to let Joel talk about this since his team manages the opiate task force.
So one of the things I mentioned last month is identifying those ways that CMH is uniquely positioned to help benefit our community. I think this is the way that CMH is very uniquely positioned, because we assist in coordinating the opiate task force, and that's a task force that's made up of local agencies and stakeholders that have been very active in the mitigation of this opioid epidemic and the consequences that it's had on our community. And so utilizing the resources that we have in this task force is helping us with this RFP process and knowing how best to use this funding. So I'll draw your attention to attachment C. I believe it's in your packet. And it's kind of a one-page overview with this opiate settlement funding. So a few challenges. One is this funding is over 18 years. That's a long time. So I don't know what the needs are going to be in 10 years from now. And so I don't want to commit funding for needs now that may change over the next 5, 6, 10, 15 years. Two is our funding is different every year. If you look at the end, we have outlined just one settlement. This opioid settlement funding is actually different lawsuits between different distributors, different pharmacies, different manufacturers that we are getting different amounts every year. So right now we have just over $514,000 in the bank that we received from one settlement in like prepayments. So we have that. So what our plan is with this initial settlement is to release like a request for proposals or an RFP with the focus on these priority areas. So the first priority is providing childcare to individuals while they're in treatment or while they're in recovery, like support meetings. So that could be like AA meetings, NA meetings, smart recovery, any kind of meetings or any kind of recovery support service. The second is to increase our availability of recovery housing. And then the third would be increase access to medication-assisted treatment. Much of these medications are focused on the treatment of opioid use disorder. So individuals who are struggling with like an opioid addiction, you might say, we call it an opioid use disorder, but those medications are focused on that. And some of them are fairly pricey. They can be over $1,000 a month. So money for that. So those are our primary focus areas. And with this RFP, we would release it once a year going forward with the amount allocated each year. So as we get more money from these additional lawsuits, we would fold that in and try to maintain at least a relative stable funding throughout the years. We would cap the proposals at 5 years. So if maybe it's an ongoing proposal, they would just need to reapply. And then those ongoing proposals would just decrease the subsequent years. And so these proposals would go through our normal county purchasing policy. They go through that whole process, and then those contracts would be up for review, just like our normal contracting process. So. You can see in that attachment C the secondary funds, the secondary priority, and then in the lawsuit, they actually outlined the other core strategies that weren't identified as priorities for Ottawa County, but they could still be used. We would still consider those if we had additional funding available, but we would definitely prioritize those needs specific to Ottawa. Any questions?
How many opioid deaths do we have in North County? Distribution of funding?
Overdoses, little deaths, right?
Was it overdoses?
It was overdose.
Overdose, sorry, thank you.
I don't want to, I can say it wrong. Yeah.
Yeah, that would be a hard number to gather, you know?
Yeah.
I see.
Yep. So how do we find the people for the RFPs? Are we canvassing them or are we just placing it on the website?
So we would go through the county purchasing policy would be placed on the website that gets out into the that gets in. So we would be able to then, anybody could apply at that point. But then they would be required to go through like our county. Becoming a contractor, we would ensure that the proper licenses are there and things like that. So, I know the last RFP, beginning of this year, Minnesota, and so it was probably
The next question was how far are we tracking outside for the RFP, especially for like a recovery, recovery program that's an AA could be singular, where it's just in one. But it also could be national, and then AA and many other programs. They've got web-based situations where it could be in New Jersey. So I'm just wondering.
So one of the things that we would make sure as we're overseeing this funding is that it's going to benefit residents of Ottawa County. And one of the things I'd like to do as well is these other municipalities within Ottawa County are also getting funding. So some of the smaller townships, the cities, and if they would want to opt into our process, we could also oversee that and ensure like individuals from that specific municipality are being served or benefiting from that proposal. So it wouldn't, the goal wouldn't be to benefit. I mean, each county gets their own funding. So ours, we'd want to make sure, and that would be part of the evaluation process for each proposal.
When the RFP is constructed, are those kinds of requirements stipulated in there?
Yes. Yep. Yep. So part of our review process would be the evaluation of the proposal.
Any other questions? All right, thank you.
Thank you.
Hang in there, a lot of information. Yeah. It was a long time ago, thank goodness.
So I invited our budget audit analyst to help present our 24 budget today. So, what we're going to cover today, budget schedule, what happens when. This is really based on the county's calendar, budget calendar. CMH, as you heard earlier from the LRE folks, we have a little different agenda for timing our budget with rate settings and some of those revenue projections. A lot of what we're doing now is based on projections and assumptions. So we're going to talk about that. We're going to talk about the county's schedule, the assumptions that we made when putting the budget together, and then we'll talk about the actual proposed budget. So in general, the budget calendars, my perspective, in February is usually when we have the board action items to discuss mills and that for taxable dollars. That gets approved here when Lynn presented actually in the last February board meeting. Our maximum allowable mills forwarded to the county board, and then they approve that. April is when we kind of kick off the countywide budget process. There's a capital improvements are initiated. We do a lot of training for requirements within the electronic health record and within the financial management system. That all kind of happens. We're here today to propose the CMH board the budget that we're representing and presenting to the county board in August. That budget cycle kicks off next week, Tuesday. There'll be, Finance Committee will be setting the dates. They'll confirm the public hearing dates and the county board dates for the budget. They'll also have first glance at where we're at, they'll be reviewing fund summaries at the Finance Committee. So any of you that are in the Finance Committee will have, within the month of August, those two meetings will be, review and, any adjustments or questions can be asked, big picture countywide for the budget. The public hearing will be in the first meeting of September. Typically, that's the assumption. We're assuming that that's the date that they'll recommend for that public hearing. And that date is September 9th. The last board meeting of September is usually when the next fiscal year budget is finalized and appropriated. So that date is September 27th. And of course, our fiscal year starts October 1st. What we didn't cover in the calendar is what happens CMH is everything right now is assumptions and recommendations and revenue projections. But really, when we get into that first quarter of the fiscal year is when we get better numbers, a spending plan that we work out with the LRE. We have more finite numbers on our grants, and that first quarter is really where we settle into what our budget's going to be. So from a revenue perspective, money that's coming in, some of the things that we made assumptions about, obviously you've heard a lot of talk here about the redetermination with the public health emergency ending and all of the Medicaid eligibility payments. That was a factor. So we kind of were budgeting conservatively. We didn't want to assume, continued growth that we've had through the COVID years, and wanted to kind of balance where we were. Milliman rate setting. So Milliman is the statewide actuarial that sets the rates for all of the services, and they publish all of their assumptions. They make recommendations. They have a whole cycle of rates information that they provide to the PIHPs and then to the CMHs on, what they're assuming for all of their rate settings. So we use those numbers. We use revenue projections from grants that we're anticipating, different programs that we're initiating or that are ending. And then another big assumption this year was the CCBHC program that we've heard a lot about. We, are on deck to, become an entrant into this demonstration as a CCBHC model. So we wanted to make some, that was one of the assumptions when putting the budget together that we'd have to consider. As far as expenses, outside of the items listed here, we really held a conservative budget. The county as a whole is projecting a 2% cost of living increase on January 1. So that was included in our budget. The health insurance increase is projected for 3%. So we included that. Medical enrollments, we maintained standard levels for our current consumer base and wanted to maintain regular service delivery, but we didn't inflate any of those numbers for growth at this time.
This is our first one, which is just our primary fund in this one. So I just want to point out, like you see all the different columns here. That adopt increase / decrease on the last one compares our 2023 adopted 2024 recommended budget. So the adopted budget is the one that we took on last October. So a lot of changes have been made obviously throughout the whole fiscal year. So we kind of just want to point out more changes that you'll see between the amended and the recommended budget. The main one really for this fund is the intergovernmental revenue change. It looks like it's a lot because it's that 8 million number there right there, but really between the amended and the recommended, there's only about $1 million. And the main difference between that is just the revenue projections we've received from the LRE, which we did a budget adjustment for that last month as well. On the expenses side for that, you'll really just see salary and fringe. There's changes there because we are requesting
11 new positions with fiscal year 24, and also just cost of living increases in general.
The one thing I did want to point out, if you recall, last month, we were still operating with 3 funds, but because we had a chart of accounts update countywide, we consolidated the mental health and the SUD budgets together. We aren't reporting those numbers separately, so it's more convenient. We don't have to do fund transfers for some of the grants that cross over both funds. So that's a little different than last year where we had 2 funds. So Cindy was just presenting on the 1 fund, which is consolidated.
And the next one, which is the millage grants fund. Once again, just pointing out the difference in the 2. So the big one is like just expenses in general is cost of living increases, that type of thing, general increases, revenue. Really, the only thing changing here big time is the new CCBHC model for revenue projections and just charges for services.
All right, just kind of a brief overview of where the money is coming from. So as you can see, 81% of the revenue for next year is coming directly from the LRE, 6% for the state general fund, and then miscellaneous covers the remainder of the percentage. Just kind of get a graph of how everything is broken down from a revenue perspective. On the next slide, you'll see how the expenses are, and this is for all the funds combined as well. This is not just for one fund. So as you can see, 66% is going directly to client care. So this is going directly out to our providers, directly out to all the folks that we contract with. And then 28% is salary and benefits for employees of CMH. And then the rest are kind of just small percentages, all within the 1 to 2% range. We've had a lot of questions on how stuff is split up because we just have a mental health fund and SUD fund. So we kind of wanted to give you a percentage breakdown based on the largest categories within the budget. So as you can see, DD services is 44% of our projected budget for next year, followed by the MI adult population at 27%. Autism is another huge category for us, 12%, and then SUD. And then the next slide shows the actual dollar amounts. So some people like to see dollar amounts, some people like to see percentages. This gives the actual dollar amounts based on our fiscal budget. Questions?
So again, I'm really just trying to understand the components. So that what you just showed, that's just the money that's budgeted, that's not millage money in that left stream, right?
Those last 2 expenditures for our program are actual client care expenditures, like they are.
Just the millage money goes towards.
That is not, this is just the mental health and SUD fund.
Thank you.
Okay.
We talked about adding 11 new positions. It's above and beyond all the positions that we presently have. Of those 11, how many of those would be indirect expense? Administrative, how many of them would be what I would call direct expense, would be those who are providing direct services to consumers?
2 admin and the rest are, I think 2. We have 1 for fiscal. There is we are proposing an analyst to assist with billing and claims. One of the big things with the CCBHC model is first and third party collections, and we want to have more. There's a lot more billing involved where there's sequence of services and also bundle services. So we want, if that comes to fruition and we become a CCBHC, we want to make sure that we can support that, and then we also have a quality position, improvement position.
And then not in here.
And the slide when you talk about how the money is spent, 68% goes towards client care, 28% to admin. And if we're starting to break out indirect and direct care, would you say that
It's not admin, it's actually staff salaries, so it's both direct care workers. Yeah, okay.
The 2% COLA increase and 3% health insurance, is that consistent with?
Yeah, they actually make those entries.
Still trying to understand CCBHC. Are CCBHC or we're not CCBHC? We are. We are. So, right now, our CC. Also, simultaneously, a demonstration site, which means, states were given money directly to stand up CCB sites within their state. So we've applied to become a demonstration site. We have not been awarded that yet. And one more time, what is CCBHC? I can't remember. Certified Community Behavioral Health. Certified Community.
Another one for the acronyms.
No kidding. So, Nick, when you reviewed where the money comes from and looking at the 81% from the LRE, when we do our monthly budget review here and we look at that lower quadrant that talks about Medicaid money, is that included in the 81%?
That is.
Okay. Okay.
Yeah.
That makes sense.
Yes, and that graph really, we've talked about where that graph kind of comes in to play about cash flow as far as what revenues have already been received, what we've had budgeted. So, okay.
Any other questions for Amy?
I do, I just want to. I'm just trying to understand can you go back to the millage one? Sorry.
No worries. Hold
Go
on.
back to the millage. How does that hold? How do you decide? X amount of dollars come from millage, and then I think last month you talked about each organization or nonprofit writes a proposal for what they need or would like to have from millage, is that right? The screen that Amy showed you was millage. So it's a combination of like CCBHC grant. We also have another pretty big system of care grant. So that's all included in that budget. That's it. Not really, but I'm trying.
Well, it's a different product. It's not LRV.
Correct.
Right, it's grants that don't come
Grants,
through
that's
the
millage.
PHP.
Right. But should the grant be listed separately? This is grant money, this is millage money. We can do that.
It is because the millage is considered the taxes line and the intergovernmental is, I know. Well, there is obvious the two funds in the tax.
Okay.
No,
That's okay.
I don't know what happened.
So this first line, taxes. Insurance. That's correct. Within this fund. So.
Can I just ask the question later?
Taxes.
$1 billion, and she's asking about distribution dollars and how that's determined. That, is there a board that makes that determination for distribution? This board.
Yep. So when we initially thought the millage, we had identified specific areas where we saw gaps in funding. And so one of those big ones was social recreational programming. Another one was programming for individuals who are more moderate to severe. So we identified
multiple areas where we felt there were gaps in services that funding might help us to provide that service. Throughout the years, when we've had additional funding, we've tried some things with millage funding and they didn't work out very well. So we had some additional funding. We then came back to the board and described whatever we need. For instance, with the specialized residential funding that we provide to several of our local residential AFC homes, that was an issue that came into play when they started describing situations where they were having the gap between what room and board was and what the expenses are or were. And also really during COVID, they identified and came to us with some real concerns about being able to keep up with payments for their staffing. And so they asked us for some solutions, and the boards previous to this one agreed that that was money that would be given to them to help support their programs to keep them running.
So that kind of explained where it went beyond the initial social rec plan.
Yep, we had, I can find that for you, but we had initial thoughts about where all that money would be spent back in 2015. And so then I can give you some background of what programming we kept and what programming kind of went by the way.
Sure. Is that something that's reviewed like annually, or how does that happen?
The millage spending? That's, so if it's, we've just had ongoing programs, and through the budget process, we put that in our budget to go to those programs. And when the budget's approved, if it's a continuation, then we will keep that funding going. We ask the programs to submit rationale and a request for funding every year. An example of a place where we just recently, and you guys were made abreast of it, of pilot kind of program with millage funding to help people with expenditures that have something to do with residential. It could be first month rent. It could be, you know, they need assistance with some repairs or making their home accessible. So
$100,000.
yeah, so that's how we've used this board as the place where we bring new ideas or we vet requests from the public when there's new ones.
You know, millage dollars are going to go up just because our taxes are all going up.
Yeah, if we have additional funding, then what I've done in the past is presented to this board. You know, we would like to increase the budget in a program, and then we'll do a budget adjustment within that program. Last year, we had some millage savings that due to having more funds than we anticipated because of taxes and some programming that didn't come in as we had planned budget wise. We did have some millage savings. We'll have some again this year. And so we'll bring to this board if there's any new programming or if we want to continue with the program that we had spent the year previous. I get requests. I got one just last week from an organization who would like to be funded.
It does have requests to CMH for millage dollars.
Any other questions for Amy? Okay.
A financial statement later, but
We have a dashboard report.
Is there any of this we can delay till next meeting? I don't know about everybody else, but my brain is fried. It seems like I'm having a hard time tracking. Is there anything that can be?
I'm gonna take just a 10-minute break. Go outside.
I don't smoke. I mean, I can start.
I answered your question indirectly, but
Keep it going, Bob.
Well, we've got the financial reports and operating budget, those we need to get through, we need to get to the executive director's report, so.
We're almost there.
Yes.
I see the light.
Hang in there, Dave.
Okay.
I promise I'll be short. I only have 2 pages.
Hi, Deanna.
I'm Anna Bednarik. I'm the deputy director here at CMH. So I'm a month into my new role. So now I get to present some new information to you guys besides what I normally talk about. So today we've got the utilization management dashboard. So this is a semi-annual report that we present to the board. It's a dashboard that's coming out of our utilization management committee where we're looking at a variety of data points to make sure that we're providing services as we should be and meeting standards. The first, the top left box, you'll see that is identifying our average number of consumers served per month here at the organization. So we're averaging about 1,600 individuals served per month. So that's an unduplicated count of per month served. And when you're looking at that chart, you'll see that gray bar. We're seeing an increase in our MI adults who are receiving services. So that's adults with mental illness. And then you'll also see we're seeing a large increase in services for children with mental illness. So we continue to provide services in a timely manner for those folks, but we are seeing some pretty large increases. If you move to the right, you'll see our FY22 Michigan mission-based performance indicators. We fondly call that MIMBUS. So this is for FY22. These are the annual numbers. On the next attachment, I'll talk about the quarterly numbers. So when you're looking at that chart, you will see that we did meet all of the indicators except for timeliness of follow-up to an inpatient discharge. So that one we were just slightly under. We were at, I think, 94.5%. We didn't quite get to the 95%. So we do put plans of correction in place for those things. We send them to the state to make sure that we're following them. And as you'll see on our next report, we're doing better in that area. The next sections are our CAPAS and TECFAS subscale scores. So these are assessments that are done with youth who have a severe emotional disturbance. And their ages from 4 up to 21 that these assessments are done. When you're looking at those charts, what we're looking to see is a decrease. So the blue lines are the initial assessment points. The green is the follow-up, and we want to see a decrease in those things. So it does look like we are having a downward trend, which means we're making a positive improvement in people's lives. Then at the bottom, we have our local psychiatric average inpatient length of stay. So you'll see in June, July, there was a pretty large increase in average length of stay days, but we have sort of settled down. It's about 9 days is our average. And then crisis residential stays, so that's short-term residential stays, about 4 to 5 days. And that is looking like it's about an average maintained at about 5, pushing up to 6 right now. Anybody have questions on the report? I don't look this way because I'm looking at myself, and that's really
Your local psychiatric stays, and like say, is that from like 22, so a year ago?
Yeah, so this is for FY22 that we're looking at. Yep. So the next time, because this is semi-annual, the data is a little off. So next time you'll see a little bit more. So if you look at the next indicators, so today I'm reporting on the third quarter, second quarter, and the second quarter I'm reporting on. So as you can see, we did meet all of the indicators except for one. So we're doing really well on indicator 1, which is admission screening dispositions within 3 hours. So that's really our crisis team meeting with people in timely manners. And so they are doing really well with that. We've also got I'm going to skip down to indicator number 4. So seeing people within 7 days of an inpatient discharge, we're also meeting that. So we are seeing people in a timely manner from discharge from inpatient hospitalization. The indicator 4B is the one that we were out of compliance with. That one, we had 2 outliers, so 2 people who did not receive an appointment in a timely manner. We are working with our contract providers to address that. It was unclear in our documentation. So that was out of 36 people, 2 people did not meet that. So we will continue addressing that. We're working on a solution with those contract providers. The indicator number 10, you can see that we're in compliance. So this is the inpatient recidivism rate within 30 days. Our goal is to not have people go back into inpatient, and we did meet that requirement. For indicator 2A and 2.3, so the ones that don't have color coding to them, those indicators will be ones that we will have a standard to report on. We have a tentative standard at this moment. Once that is more finalized, I'll share it with you guys, and we'll be reporting on these in FY24. So any questions?
Thank you.
All right, thank you.
Is there any old business? Business contract approval process.
So I just wanted to go over what our current process is for approving contracts. About 2-3 years ago, the previous board agreed that all new contracts, amendments that resulted in contracts over 50,000 and renewals over 50,000 would be brought to the board. Contracts that did not meet this criteria are approved internally by myself, finance director, and then routed for signatures through the board of commissioners chair and the county clerk. And if that's okay with people, that's the way we'll keep going.
That exists as an unwritten policy. And I guess my reaction talking about that is that regardless of what the dollar amount may be, it probably ought to be defined as policy. And it should be written. And then we rely on that. That's not always. So, and then the next question would be the dollar. If people comfortable with 50 or wouldn't think it would be any more than that. We want something less than that. That's not something we have to settle today. It's something you want to give some thought to. Or another option is I can work with when we can craft a draft policy and then bring it to the board at the next meeting for review. Possible approval.
So this has been addressed before. How many contractors fall below that threshold?
Yep, it is a good question.
Just in a percentage.
I will have to go back and check. You don't have to name off the top of your head.
So now, 200, including the original contract, so that's contracts which is loaded, that includes amendments of for any modifier changes. There's no monetary change. So it's a lot of variation. That fall under that.
So the contract might be amended for code change or a modifier change. It's not always even a monetary amount. But what we can do for you, I think your idea is a good one. We can work on a draft of a policy and I can get that information to you, what the percentages that falls above and below that cutoff. Yeah, yeah.
So we're not sitting on.
Yeah.
Assuming we're not sitting on 60% falling below the threshold. We're just looking at the cherry picked.
Right. I can get that for you. It's a good idea.
One provider. 6, 7.
So we're in agreement that we do the policy. And then Lynn and I can work on a draft, bring back to the board my concern again would be changes, even amendments that deal with dollar amounts. The non-dollar amounts, it's just procedural change that's driven by the state. I don't, it's myself, I wouldn't be concerned about that. It's gonna be driven. Yeah, that's true. That could be the case. Okay, all right, we will do that and prepare that for the August. Service contracts.
No.
Yeah.
Okay, all right. So this month, we're requesting your support to move forward with 6 contracts. And the first one is for $35,000 through CCBHC grant funding for an organization called Credible Mind. And that's to create a mobile and computer web platform that we're going to use to provide mental health resources and wellness and educational type stuff. And that is through our current CCBHC funding. The second one is for $13,500 to organize a website. And then $1,000 a year to host and maintain it through an organization called WebTrack. And this is through our System of Care grant dollars. And really that's a website that we currently have, www.stigmafreeottawa.com, that we're going to try to beef up and have more control over. The next one is for $3,000 for Yellow Line Creative, and that is to create a new logo for our System of Care. The current one, it's not very clear. It doesn't show that it's an Ottawa County initiative. It doesn't show that it's that's a collaborative with different providers. So we want to create a new one that meets that need. The next one's really cool. It's called the Carter Kits. And this is, we have some grant funding. We'd like to purchase up to 400 kits that would be available for first responders when they work with someone that's on the autism spectrum that is having a crisis. They would have some tools, a weighted blanket, sunglasses, the headphones, and that type of stuff that would help de-escalate the situation. So we'd like to have that so first responders would have that available in case they need that. The next one is a environmental modification request. This is for a child and family in the Children's Waiver Program to have their bathroom remodeled, so they would be able to continue to live in the home, basically taking out the bathtub and having a walk-in shower type thing. And then the last one is a renewal with the Michigan Department of Health and Human Services. And we have a position that's housed here for somebody that's able to go through and do like eligibility determination type stuff. And yeah, that's a really valuable resource for us. So those are the 6.
I never heard the Carter Kits. Is that where they come from, the person or company, or what is that?
Yeah, it came from an individual. I cannot remember what state. I believe it's Utah, but don't quote me on that. That oh goodness, I just saw myself up on the camera. That were he's a first responder, firefighter, the policeman that had these situations happen where he's like, oh my goodness, I wish I had some better tools for dealing with, a child or an adult with autism. And he actually created this, started this company. And it's evidence-based, I don't know if evidence-based is the right word, it's evidence supported, that it is beneficial. And folks that use it in different environments, they're using something somewhat up in Coopersville right now. But we'd like to, get it to as many folks as we can. The 400 kit, the $30,000 and purchase 400 kit. Right now, our plan is to get 200 that are the full kits that would include the weighted blanket And then 200 are the junior kids that would have everything but the waiver blankets. Oh, I'm sorry. I hope you heard that. Okay. So, yeah.
I have one question about the classic remodeling one. Children's waiver, what age? Is that 18 or adult? When did it go from children's waiver?
It is 18. Yeah, there's other, the HAB support waiver will also pay for remodel.
Back to the Carter kids, first responders, that would include our local law enforcement.
Yes. So we're looking at law enforcement. We'll train 3 staff, and one is Tim, who works with the county law enforcement folks. So then there's a training to share what the tools are, so folks will be able to use it. And that'll be our first grouping. And then we'll kind of move down from there to school systems and, other places, depending on, how many we are able to distribute.
Especially with that too, being a retired firefighter from the area. So, a lot of us did not have training, specialized training with crisis interventionalists. So being crisis interventionalist typically is, therapist focused. I'm just wondering, I feel like I'm getting into the weeds, so I apologize, but where's the training coming from? And then, law enforcement does a really good job with it. But...
Oh yeah, the training is through the Carter Kids folks, and then it's a webinar based thing, and then we would have to take a test before we'd be certified in it.
A portion of that too may just giving people the ability to recognize that you have a unique situation and then what to do in that circumstance. Not necessarily the treatment itself, but I've got a special need here. Now, what do I do? That's particularly important with law enforcement. All right, any other questions on any of the comments? If not, I will take a motion to approve.
So move.
Report. All in favor, say yes.
Yeah.
Opposed, the same.
So as I mentioned earlier, this was the month where we are reporting for the first time with our mental health and SUD fund combined into a single fund, so that if you're looking at financial statement page, it would be in the upper left corner. Again, continuing in a healthy position financially. We're projecting on target for our revenues and expenses. We have a little, increase over in that position from last month, but combining those funds, 63% of objective of 75% target right now for this month is a, pretty good position to be in. We're not lacking funds, and we're not too close to that budget. The last quarter is really where we clean up all the owners. We're really working hard on encounter data going back to the start of the fiscal year. And we'll really have a big push with our provider network to make sure that we get all our claims processed for some third party, secondary claims are processed in a timely manner. So I think we're in a good position to be able to do that effectively. So in the absence of the SUD fund in the upper right corner, we put together, we're thinking, how you like this, but we did expense detail by so you kind of get a sense of where this is all client care based and the programs. Some of those programs that we talk about, you can kind of see relative to other programs, how much of the activity, how much of the expenses are directly funding those programs. So on your page, but good information. Just general. You may, you know, if you have any comments, you may consider adjusting some of those things as well. The new chart of accounts gives us a lot more flexibility for reporting, so we're able to report on some of those levels of detail that we didn't have in the past. So again, millage and grants, we actually officially renamed that. It had been a fund that was exclusively millage, but we started putting grants that didn't come from the LRA there. And we had a lot of questions like we had today where we had to explain that. So it is a millage and a grants fund. You can consider that the revenues are property tax, that's the millage dollars, intergovernmental, actually called grants here, are grants. So, again, in a good position, we're, projecting, we had a slight increase, year to date in, 57% spent to our budget in that, fund, so another good position, you know, not too close to the 75%, but still in a healthy expense trend. Total Medicaid funding, Medicaid budget to actual. This is the first month that we've had a little under our budget to actual. But if you recall, we actually adjusted our revenues last month, so it kind of brought that back together. Because we have a surplus, you know, we have monthly projections that the LRA provides, so those revenues are in line with our spending, so there is no area of concern there. It's just one of the first times where, you know, payments fall in and where we were projecting we would be, like July at the start of the month was very close to where we are actually budgeted, so not a bad position to be in, but nothing to be concerned about either.
Detail by primary. Interesting to see, looking at each of those categories as a percentage of total expenditures.
Okay.
And how we manage. Interesting to see a comparison. So when we look at how much we spend in services and my services, how we process it.
Okay, I think we can do that broadly, but there's so many different, I think, service mixes by CMH, but. So, sorry.
Just, well, I would think most of them
By
are categorized,
population, yeah.
categorized by population.
I think we can find, I'm sure there's information published out there. Align our numbers.
I like that graph. Helpful. Yeah, it's medical necessity, really. Keep in mind.
Right,
Yep.
right. But we need to see over time too.
Any other questions? All right, yes, I need a motion then to approve the financial report.
So moved.
Or, favor say yes.
Yeah.
Opposed? Operating budget.
Oh, you do a motion for the 24 budget? Oh, is that one?
Just do the financial.
Yeah. These are the, do you have the motion that it's at, yeah, for the actual 24. These are the fund summaries that are presented and from our presentation. So I believe it's the board.
Yes, please.
To recommend.
Which attachment?
It was your presentation.
It was a
earlier.
presentation.
I think I also
Everything.
included, yeah.
Going back to that fiscal year 2024 operating budget as presented to reviewers. Do we have a motion to approve? Presented. Move. Board. Discussion. Comment or questions? All in favor, then say yes.
Yes.
Opposed, the same. LRE combined monthly report.
And this is the monthly report standing through May. We presented it at this board last month, so kind of old news, but it is nice to see comparison. MHs, that's good information. Again, we're in a healthy position and continue that same trend.
Any comments or questions on the report? Very good.
So from the states, continue to pay attention to that public health emergency unlimited Medicaid dollars. Really too early to tell what that's gonna really shake out to be for a budgeting or our revenues. We'll keep an eye on continuing to look at staffing issues. The budget was passed with an 85-cent pass-through for direct care worker. We had asked for, applicants were asking for a $4 increase, and that didn't happen. The 85 cents is good, but clearly doesn't get folks to a level where those wages are competitive at this point. So we'll keep advocating. There is a lot of discussion about conflict-free access and planning. Really what the issue is that the Centers for Medicaid and Medicare Services calls for separation from organizations who provide access, person-centered planning, case management, sports coordination from those who provide the service. Their proposal at the department would create a separate system that would do those functions from the CMHs. There's a proposal to put that at the PHP level. And there's quite a bit of pushback from the CMHs, from the board association. We've talked to individuals about their concerns about having separate systems. So you go get your intake someplace, then you come here for service. It's my opinion and the opinion of many others that there are safeguards in place that really prevent, we're government entities, there's no profit to be made in having doing your own assessment and then providing the services. Any money that was not spent on services goes back to the regional entities and the state. So there's really no motivation there. There are listening sessions that the department is putting on August 1st and August 9th. It's an ability for families to speak their mind about how they think that system should look. And we've been advertising those meetings on our social media, and we'll keep doing that up until those dates when those meetings have occurred. The other thing that is we've talked a lot about, there was a directors forum meeting last week and the department was invited. They've been really working to create a better partnership between Michigan's child welfare system and the community mental health systems. So working on clarifying roles, what kind of support foster parents might need. They're also working on quite a few options for treatment through the My Kids Now, the lawsuit that happened a couple years ago and is still in the process of being rolled out. And so some of those options include the program we're running and starting up the mobile crisis for kids, intensive crisis stabilization. There are also some other treatment options like therapeutic foster care that is being piloted, all with the effort of trying to improve services for kids who are experiencing mental health crisis and mental health needs. So I'll keep you up to date on that. I wanted to let you know that Kristen Jordan has taken Jeff Weaver's place as the Bureau Director for Specialty Behavioral Health Services. She starts July 24th. She's someone that is familiar with our system. We have worked with her in the past, so I think she'll be able to hit the ground running. We talked a little bit about CCVHC, that we submitted our continuation. It's called Improvement and Advancement through the SAMHSA program, which is the federal government. And then we also just submitted all of our required documentation and reports for the demonstration project, which is the state project. You can have both simultaneously. I think today was our deadline to answer some questions, so I'm hoping we did. There we go. We submitted an hour ago. We will know, I hope, in a couple of weeks whether or not we've been accepted, whether we get both that INA grant and which is kind of a continuation of the previous grant with some changes, and that demonstration program. And my staff have been unbelievably busy getting all of that submitted. They've done nothing else really, a couple of them, including Anna. From CMH, I wanted to let you know that I have submitted to John Gibbs, Finance and HR, a request to have change one of our current positions. It's our IT program coordinator to an IT program supervisor. What we have found with the addition of these grants is that we have that much more work on our hands in trying to take care of all the data requirements. Our electronic health record is obviously the kind of the backbone of the work that we do here. And as we add staff, we just have more and more requests for assistance in having that electronic health record do what we needed to do in order to help run our business. So I meet with John this week, so hopefully I'll hear I let you know last month, excuse me, that Dr. Drum was resigning. Permanent agency. Basis to provide supervision over a minimum. For us. So it's well. Wanted to let you know that we were awarded a 3-year accreditation by CARF. The strengths that were pointed out to us in that evaluation included dedicated employees with a broad range of clinical experience, a strong commitment to the health of people we serve and employees, collaboration with community partners, an appreciation by the people who were interviewed and the person served for the services and the staff who provide those services. Comments were that they were caring, non-judgmental, responsive, and helpful. CARF is one of those requirements through our contract, and as much as it's a challenge to get prepared and meet all those requirements, I think it's also a really good checks and balances for us to have a third party come in and kind of measure us compared to other agencies that do similar work. So we did have a couple areas where they recommended that we change some things or add some things. So that happens every, in most cases, I would imagine, where there are some recommendations, and they weren't anything that we didn't feel like we could address pretty quickly. We also had our 3-year recipient rights assessment last week. So the recipient rights office from the department, Michigan Department of Health and Human Services, comes in and spends a couple days reviewing all of the work that Brianna does and our recipient rights process. And she scored 155 out of 176. 155 out of 100. Oh, sorry about that. Yeah. That's the non-weighted score. The weighted score was 399 out of 402, which is still pretty amazing. Yeah. And Brianna, and our rights program typically does really well on those audits. So again, some great work on behalf of our staff. I did want to follow up with a couple of things from last meeting. I just, during the meeting, heard back from Human Resources about the request to allow families to use our Indeed account and possibly advertise positions on our social media sites for those families who are using self-determination. They want, HR is asking for us to get together with them to discuss that in more detail. So I apologize for not getting, having that move further, but I think we can make some work of that over the next month. And one other suggestion was for us to get a banner on our webpage that announced meetings, and we're working on doing that as well, similar to some of the other, so the Parks Department has their own banner so that people just simply have to click on that if they want to join the meeting. I did want to offer to the new board members or old board members, I do realize that this work is pretty complicated. We have lots of things that we're involved in, lots of data that we're responsible for, and I'm happy to sit back down with people if they'd like, sort of a second round of orientation. I know I got most of you guys, but it was sort of a whirlwind. So now that you've been here for a while, you might have some more specific questions. More than happy to sit down with any of you individually or together to go over whatever questions you might still have about what we're doing. We do have one meeting. We used to have 3. One was a committee called Program Planning and Quality Improvement, and the other was Finance, and those met separately. And it was the recommendation of the board that all of the programming that we do and the finances that we are involved with are important enough that the entire board should hear it. So that's why we combined it into one meeting. And again, I'm happy to provide whatever level of detail. I know Amy, we made some changes on the finance report, but we're happy to provide whatever level of detail you'd like or in whatever format you'd like it in. That's no problem at all. And I will leave that.
Okay. Thank you. Yep. Any general information, comments, meetings attended, anybody wishes to share? If not, this is final opportunity for public comment. We'll start with folks in our boardroom. Anyone here wishes to make comment? Yes, sir.
Hi, my name is Stephen Rothman. I had joined this meeting online and I had my hand up, unmuted, microphone was working. And for some reason, I was not recognized and not open up to be speaking. I was on the chat group and participated. So that's why I'm here. I wanted to do it online because when you speak, the public can hear you better online than to come into this room because there's no microphone for the individual speakers. And I've heard that brought up too, and I hope that it becomes an opportunity. So this is my comment. My comment is about the hue and cry to cancel Jason Monroe. The political lynching is over his email to Rolling Stone author Michael Klee about his review of the movie Sound of Freedom. The title of Klee's article is Sound of Freedom is a superhero movie for dads with brain worms. It largely downplays the horrors of child sex trafficking and ridicules those who are concerned about it. Rolling Stone had a meltdown over Sound of Freedom, and out of county, we're having a meltdown over wrong speak. The movie is about the real-life adventures of Tim Ballard fighting child sex trafficking, an objectively heinous evil. To sum up Klee's article, he wrote, Ballard, Caviezel, and others of their ilk have primed the public to accept Sound of Freedom as a documentary rather than a delusion by fomenting moral panic for years over this grossly exaggerated epidemic of child sex trafficking, much of it funneling people into conspiratorial rabbit holes and juvenile communities. Mr. Monroe is being attacked for his email to Klee. Monroe must have been over target because he got doxxed. The outrage is over the use of the word retard. But this is a contrived controversy by the left against a new CMH board member appointed by the new Board of Commissioners. The left is at war without an impact. It has seized an opportunity against Jason Monroe. The outrage is over the top. Much of it is probably feigned and being used as a political bludgeon. But back to the article. Why would you ever downplay child sex trafficking by calling it grossly exaggerated, the movie a hackneyed white savior narrative? The cynically outraged are screaming about the word retarded. Can you imagine an actual survivor of child sex trafficking reading Cleve's words that goes beyond just cruelty and callousness? I thought if even just one child was sex trafficked, that should be one too many. Yet Cleves has all but dismissed child sex trafficking as little more than a made-up boogeyman. Cleves ends his review attacking the far right, of course, and sex abuse by family members. But apparently because there are children who are sexually abused by family members in the world, we should just stop caring about international child sex trafficking rings. Frankly, what Mr. Monroe wrote showed great restraint. I think some pejoratives are in order.
Stephen, your time is up. You want to wrap it up quickly?
Yes, thank you. In context, he was not attacking the developmentally disabled, but using the word in the context of a very foolish person. He will not be permitted to have a colloquialism. Instead, it becomes a struggle session, like I've watched today.
Thank you. Any other comments from anyone on the board? Any comments online, Patricia?
Hi, I have a comment.
Go ahead, please state your name and where in the county you're from.
Thank you. This is Jewel Wickman, Ferrisburg. I wanted to comment on the IT infrastructure that CMH spoke about. The thing is that the CCBHC is a soft infrastructure. People think of it as a hard infrastructure. It's not a brick and mortar necessarily. It's made up of numerous community providers who provide data collection on the individuals served to promote this socialized healthcare reform. So that is why they want all of this data collection and all of this software to support that. So I just want the board to be aware of that. I'm also asking for details about the benefit plan, the behavioral health initiative for people who are unenrolled by the Medicaid health plan. There was no discussion at all today of programs in the contract that state that the contract title is Medicaid Managed Specialty Supports and Services 1115 Demonstration Waiver, the 1915 CI waiver programs, the Healthy Michigan program, the Flint 1115 demonstration program, the Substance Use Disorder Community Grant. None of these were referenced specifically in regards to how much money was given for each program and the people who are eligible for these programs and who are currently involved. Right now, I am requesting a presentation on the 1915I state plan amendment plan because several people are not being allowed to be enrolled in this plan. This plan also provides for housing. So when Lynn Doyle states that the millage is to pay for gaps in services, I am absolutely begging the board to ask, what are the gaps in services? Gaps in services phrase are thrown around every which way all the time in requests for money, but no one actually knows what that gaps in services are. So I FOIA'd the specialized residential applications. And apparently the gaps in services are because CMH in some situations have taken away home and community-based CLS, community living supports services from people in adult foster care homes. And then they have no alternatives but to then go into a CCBH social recreation program where data collection is being taken for their CCBHC healthcare reform initiative. So I am begging the board to please look into that because if services are being taken away from people that they're being left with no recourse but to go to Momentum or other social programs, I don't think that is the right thing to do. I think it's a conflict of interest. And also regarding the conflict of interest that Lynn stated in a public comment, CMH leadership admitted that self-determination was a substitute for support coordinators. So what that means is the reason why CMH is pushing back on conflict-free case management is that if people are given the power
Thank you,
to
Jill. Your time
choose
is
their
up.
services, then there's
Thank
no
you,
need
Jill.
for case managers.
Better off. Is there anybody else online that has a comment? I will take a motion to adjourn. Support. Yes.
I was wondering like, what's Joe?
I ordered a pizza just now.